Welcome, aspirants, to today's explainer here on the Rungta IAS Academy channel. Today, we're dissecting a really critical topic for your GS Paper 2, spatial inequality and health.
Exactly. We're going to examine how residential segregation practically dictates public health access in India. So let's dive straight into the structural inequalities that are actively shaping these outcomes on the ground.
Now let's start with a really profound observation from community medicine expert Dr. Nancy Angeline. She says the line drawn was not geographical, it was caste. And this perfectly captures that invisible boundary in our public policy. It's what determines who actually gets a health center and who gets excluded. It shifts the entire problem from just a simple lack of resources to deeply inequitable spatial planning. This is excellent fodder for your mains essays, by the way.
Right, but qualitative course absolutely must be backed up by macro-level data if you want those top marks. And the recent working paper by Sam Asher and his colleagues is absolutely perfect for this. They literally analyzed over 15 lakh Indian neighborhoods. So when you're writing your GS2 answers, citing this massive, specific data set adds immense analytical weight to your arguments on social exclusion.
So what did this macro data actually reveal? Well, the Urban Segregation Index for scheduled castes stands at a staggering 0.59. To put that into perspective, practically speaking, it means over half the scheduled caste population in urban areas would literally need to relocate just to achieve full integration. Segregation isn't a thing of the past, it is actively shaping our modern cities.
And the situation is similarly stark when we look at urban Muslims, where the segregation index is 0.52. Strikingly, nearly 1 in 4 urban Muslims lives in neighborhoods that are over 80% Muslim. This kind of ghettoization isn't just a demographic fact, it translates directly into an absolute barrier to basic service delivery.
When you look closely at marginalized communities, you realize it's not merely an issue of poor housing or bad roads.
Precisely. Neighborhoods with high Dalit and Muslim concentrations are systematically denied schools, health centers, piped water, the whole shebang. And this lack of basic infrastructure leads directly to delayed medical treatment and much worse health outcomes overall.
Let's ground this abstract data with a micro-level case study from Tamil Nadu. We're looking at the dominant caste area of Valyur versus the Dalit settlement of Magishapuram.
In Valyur, you had paved roads, you had the health center, but Magishapuram was physically separated and completely neglected.
Citing localized examples like this in your exam shows the examiner you truly understand how public amenities are captured by dominant groups.
And this physical distance creates real structural exclusion. Take the example of an Anganwadi that is purposefully placed in a dominant caste area.
There was a tragic case of a Dalit mother who completely avoided it, even though she had a severely malnourished child. Why? Simply because she faced humiliation every single time she entered that dominant area. So the barrier here wasn't a lack of awareness, it was fundamentally a barrier of dignity.
Moving over to Odisha, scholar Tanya Tanisha Mahanti's fieldwork near Patia reveals another really concerning layer to all of this. Her research shows us that social identity dictates not just where people are allowed to live, but who they are even allowed to ask for care from.
Exactly. In Patia, Dalit access to the single local clinic, which of course was located in an upper caste area, was restricted to fixed days and hours, just to avoid offending the dominant residents. From a public health perspective, this is nothing short of a catastrophic governance failure. Think about it. If a medical emergency occurs, especially for pregnant women outside those specific hours, care is completely out of reach. Make a strong note of this for your critical analysis sections.
Shifting gears to Maharashtra, researcher Shakib Ahmed Khan's findings in Nagpur prove that this isn't purely a rural issue or just a caste-based issue.
Indeed, in Nagpur, Muslim-dominated areas have significantly weaker infrastructure. This clearly proves that minority ghettoization in our urban spaces directly results in systemic healthcare exclusion as well.
And Khan highlights a compounding problem here, which is provider bias. The health centers in these marginalized areas are already understaffed, but worse, the providers often bring inherent prejudices right into these spaces.
For instance, supervisors falsely attributed higher disability rates in the community to consanguineous marriages, completely ignoring actual prevalence data. These biased assumptions ultimately force marginalized residents to seek out expensive, out-of-pocket private care.
So, what is the core administrative issue driving all of this? It's what we call the policy blind spot. See, welfare policies often assume that a district's health service is equally accessible to absolutely everyone living there. But district-level data completely hides the harsh realities of neighborhood-level segregation. You definitely want to use this concept to elevate the critical analysis in your mains answers.
Now, how does policy actually interact with this issue? Well, some reports, like the Sakhar Committee report, formally recognize this ghettoization problem. However, as civil servants, you need to objectively analyze policies that might exacerbate it too. The Gujarat Disturbed Areas Act restricts certain property transactions, and in Assam, eviction drives are reshaping settlements and disproportionately affecting minorities. In the exam, your job is to neutrally report these observed effects on spatial inequality without taking political sides.
All right, any good UPSC answer needs a solid way forward. So how do we fix this?
First, administration needs to recognize neighborhood-level barriers, not just look at district averages. Second, we have to dismantle geography and identity as hurdles to care. And finally, we need to abandon flawed concepts of centrality and actively redistribute facilities, placing them directly within marginalized settlements.
To wrap up today's explainer, I want you to consider this potential UPSC interview question. How can public administration dismantle geographical barriers to ensure equitable healthcare delivery? Think about it. Use the macro data and the micro case studies we discussed today to formulate a really structured, data-driven answer. Thank you so much for tuning in to Rungta IAS Academy today. Keep analyzing, keep linking current affairs to your syllabus, and best of luck with your preparation.